put your name and contact information into the chat. Bailey gave us the notice to go ahead and get started. So welcome to today's Time to Act Mental Health Echo. We're glad that you joined us today. We are recording today's session. It is stored on our Canvas page as well as on our YouTube channel. So you are always able to go back and watch it and share it with other colleagues or family members. But we do use that recording for educational and quality improvement purposes. If you've never joined an ECHO session, welcome to your first one. They are a great way to learn information, learn about and get connected to other colleagues in the field throughout the state. So please reach out to people. We have our amazing hub members on our call. They are some of the experts in the field. They all have asterisks in front of their name. So if you ever have any questions, you can reach out to them. ECHO is an interactive community, so ask your questions, put them into chat. Also consider doing a case presentation. That is a great way to get information for the families and clients that you are working with. We do talk about some sensitive topics, and we talk about the clients that we work with. So please remember to protect their individual privacy. Avoid using any first, middle, last names, identifiable information. If you have any questions, again, reach out to one of our amazing hub members. They'll answer any questions for you. The key components of an ECHO session are a didactic speaker, a case presentation, and then we go into breakout rooms or stay in the main room and talk about the case. Today we will be doing some breakout sessions. Those are a great way to, again, just share information, talk about the case, information that we've heard on the call. That's the difference between what an ECHO session is and a webinar is that it is more interactive. If you've not taken a minute, please rename your profile with where you work, what your discipline is, whatever you want to share, just so we know who's on the call. It really helps our speakers as well as other people on the call to know who is attending today's session. We've all been on Zoom, so we probably know how to raise our hands and put questions in the chat, but you can always do that. Registration is how you'll always know when these sessions are. If you would want to pre-register, you can do that. You can also email any questions at timetoact@aggies.usu.edu. We try to share information ahead of time and send out those materials. In order to get a credit of attendance, we will be dropping in the survey link throughout today's session, as well as emailing it out after the session. So that is how you will get a credit of attendance or certificate of attendance. We will also share with you all access to our Canvas page. If you have any questions or just want to request that access, you can again email us at timetoact@aggies.usu.edu. Just another plug for those case presentations or case narratives, case discussions, whatever you want to call them. They are a great way to gather information, gather amazing resources and recommendations to take back to the families that you're working with, or just increase your knowledge base. So please consider doing a case presentation. We have us on social media. If you want to follow us, these are all of our links. We share resources that people share with us, information about upcoming sessions, and then just evidence-based that is out in the field. Thank you for joining us today. I'm going to stop sharing and turn it over to our amazing speaker, Ilse.
Thank you so much. That's very kind. And I will, let me see here. I'm going to make sure I'm sharing, and I will minimize the chat because I know someone else is monitoring that for me, and then I will share my screen. But before I'm going to share my screen, what I would like to do, if you are willing to participate, is put your view in gallery view and look at the faces that are currently online. So if you are willing to, for this little bit, to open your camera, that would be amazing. Because what I would just like to do is to basically non-verbally acknowledge one another, look at all the faces. You don't know who's looking back at your eyes, but you just look with curiosity at all these beautiful faces that are here. See some of them familiar, some of them not familiar. But all of us here are here because we are interested in mental health and in babies, working with families typically, and wanting to do the very best with that. So welcome everyone, and thank you for showing up and opening your video cameras for this little bit. And then I will now share my screen, and let's see, share sound, share. Okay, can you see it? Okay, good. Okay, then let me open the slideshow and begin. So first of all, thank you very much for inviting me to present on this topic. I have to say it is a very large and a little bit of, intimidating topic because it has so many factors to it. I have put together, I think, a nice mix of some real good information about infant mental health and how we practice it, as well as these disparities that we all need to be aware of. And before I dive into that, I wanted to share this beautiful piece of art that some of you may have come across on social media because it's been shared quite a bit. And it's a drawing by a 13-year-old girl who basically was asked to draw what it looks like to have peace in the world. And it immediately reminded me of my topic because we have such a diversity of people in this world. And today we have so many tensions and, different perspectives and not seeing eye to eye. But we also have a lot of positives. We also have a lot of great initiatives, that a lot of you are engaged in to really increase that connection between all people. So okay, I was asked to say my full name. My name is Dr. Ilse DeKoeyer. It's Dutch, and so that's why it's a little bit complicated to pronounce. But yeah, Ilse DeKoeyer, and I worked at the University of Utah for 23 years. I did parent-infant relationship research there with Dr. Ellen Fogel. And then I taught undergraduate students for about 2 decades in psychology and family consumer studies. And I'm still teaching in the infant and early childhood mental health certificate as an adjunct, only in spring semester, but I'm proud of that certificate because we need more education in this field. Now, I'm also very happy and proud to work at United Way of Utah County, mostly with Help Me Grow Utah and also with Welcome Baby. And Stephanie Anderson is on the call, and a lot of my colleagues from United Way, which I'm really happy to see your faces. I'm also a founding board member of the Utah Association for Infant Mental Health, and I'm on several committees that work on behalf of improving infant mental health in Utah. And then Help Me Grow, you guys probably all heard of it by now, but I do want to put a little plug in that we give excellent information on child development and parenting for young kids, as well as a variety of screeners that are in support of promoting infant mental health as well. So we have social emotional ages and stages, and we have the MCHATs and the Edinburgh postpartum depression screening. Our parent support specialist team is absolutely amazing. They are very knowledgeable on resources and how to connect families. And also they're just very empathetic and just a nice person to have on the phone for parents, so that parents can be more empowered to support their children. My job is early relational health specialist, and I'm supporting the whole team in that fostering of early relational health. So the Infant Mental Health Association, I've been in it since 2003, so that's a long time. And we mostly put on an annual conference that you see on the flyer over there. We just have the speakers lined up. And then we also are promoting this infant mental health or early childhood mental health endorsement system. These slides will be shared. So if you're interested in it, you can go there and see how you can get endorsed for your knowledge and expertise in the field of either infancy 0 to 3 or early childhood, or you can do both as well. So yeah, and also, by the way, let me know if you have questions in between, and I will be happy to answer them. So just a brief reminder, some of you may have been at the amazing presentation that we had a couple of weeks ago by Dr. Sandra Stegenga, who is a colleague at the University of Utah. But I just wanted to go over some main points. So we have three main functions. Promotion of the best optimal infant mental health, relational health, social emotional health that we can provide to children and families. We want to prevent problems from getting bigger. So often in young children, you start to see maybe some symptoms of behavioral dysregulation or anxiety, well, autism, of course, is one that we can identify early on, but we can start to see symptoms. And then when we provide support to that family and child, we can prevent bigger problems from happening. There are also specialized interventions. The Children's Center is our local center of expertise for that, where there's therapy that targets mostly parent and child together to improve that relationship. It's an interdisciplinary field, which is really exciting because it goes across like medical care, social work, psychology, early intervention, home visiting, all these professions, anyone working with babies or young children, and have a relational orientation. So we also call this field sometimes family infant mental health or parent infant mental health, because babies do not exist on their own. They can't exist on their own. And that's, kind of simple in a way to say that, but it really is true. They need us, and that's why they're wired to connect to us, and we are wired to connect to them. So the main ingredients for healthy emotional infant and early childhood mental health is the developing capacity of the child to form close relationships, manage and express their emotions, and explore the environment and learn. And all of that happens in the context of their family, their community, their culture. And this little kid over here, this little picture, I always love to see his eyes and how they're so beaming with joy and liveliness and exuberance, even though he seems pretty calm. And I think that's, one thing that we can see in infants. We see that vitality, that presence, that willingness to connect. And it's so beautiful to go back to that and to hopefully make it alive in our own selves again. So in terms of close relationships, bonding is important, but attachment is really foundational because it provides that secure sense, that secure base, out of which children feel comfortable to explore their world and learn. Of course, we all know it's really important to manage and express our emotions. And this takes years to develop a regulation of that process. So we often have to tell parents, just repetition, repetition, repetition. Their brains are growing and that will help. But at the same time, young children really need co-regulation. So before they can self-regulate, they need to have a co-regulating other that helps them feel like, okay, you can get upset, but you can calm down. It's okay. And then they'll find ways to do that for themselves. But you are their model, you are their resource initially to help develop those skills. And then, yeah, when they feel safe and secure, they will naturally explore other people and things around, and they'll just go for it. They're curious. I briefly want to share a study that found 3 basic ingredients for secure base development. So this was a high-risk sample. And I wanted to share this too, because when we work with families at Help Me Grow, especially families living in poverty, families of color, we have all these beautiful parenting tips, but they may not have the time to implement, or they may not, they may feel like, oh, that ideal is way out of my reach. I cannot never get there. So luckily, we don't have to be ideal. They found that if you soothe a crying baby chest to chest for at least 50% of the time, until they're completely, when they're crying really hard, and then they go like, and then they completely calm down. If that was done 50% of the time, the child developed a secure attachment relationship, along with not interfering with them when they're happily playing and delighting in them, but only when the baby initiates. So when the baby's showing you a toy, the baby comes to you and, puts their arms out to you, show that delight, that joy, like, hey, I'm happy you're here and you're beautiful. And Dr. Barbara Stroud, who's one of our speakers in the UAIM conference that's coming up, she said, every child deserves someone that is hopelessly in love with them, will love them unconditionally, and provides them with a mirror image of themselves as brilliant and beautiful. Honestly, I wish this to all of you as well, to us as adults, that we have someone that looks in our eyes and mirrors us back and shows that we matter. This is just one way that we can fuel and support relationships that help all of us grow and develop. Luckily, parents do not have to be perfect, but it's still harder for those families who have all of these major challenges to feel secure inside of themselves so that they can offer that secure base for their children. So poverty will make it really hard to feel secure, domestic violence situations, mental health challenges, and discrimination that is due to racism. The color of your skin, I put those 2 separately because you may or may not know, but all across the world, cultures and peoples tend to prefer, for some reason, lighter skin and discriminate against people with darker skin. That is a phenomenon that happens all over the world. So race in itself is kind of mixed with that, but it's not necessarily the same. Dr. Marva Lewis, who was one of our UAIM speakers a few years ago, she really emphasized that element of colorism. Then there's differences due to ethnic background or ableism, like when someone has different physical or mental abilities and don't show up completely as we may expect. Usually it's when we don't really know the other person. We're not really open to the other person, and we have biases that we may not be aware of. And if parents come across that, then it is very hard for them to be that secure base for their children. Maybe before I go on with the next slide, I do want to say that if parents can, even amidst these circumstances, if parents can provide the secure base, then this can buffer the child from multiple risk factors. So if we can help to secure that relationship more and support it as much as we can, this is going to help the child's secure relationship. And to support this parental resilience, perhaps the most important tool is you, all of us. So of course we need content. We need the, relevant information. We need skills. We need to educate parents and caregivers. But there's also the process of how we communicate and how we show up. That is very important. We are here in the field of infant and early childhood mental health. We emphasize that we are here to hold space for the parent. We are basically a co-regulating other for this parent. We show up with curiosity and openness, not with just, I'm the expert and I will tell you X, Y, Z what to do. We may have that knowledge, but we're still curious and open to what works for this family or what concerns them or what they're going through. We want to be humble, so knowing that we can never know the complete circumstances of any other person. So yeah, again, don't step in with all your knowledge, but hold back. Some of you may have done the FAN training with the Children's Center or anywhere else. And FAN has this notion of a drop, just a drop of information, and then let that sink in and see how that lands for the family. Willingness to learn and adapt, and celebrating this diversity, this uniqueness of every single person that we work with. Listen. Again, don't keep talking all the time. And here's a really famous quote from the field of infant and early childhood mental health by Dr. Jerry Paul, who is probably the most quoted person in infant mental health field. How we are is as important as what we do. So a couple of years ago, actually about 10 years ago, a paper was written that has diversity-informed tenets for the field of infant and early childhood mental health. And the first one is probably the most central one. We need to be practicing self-awareness of our own strengths, our own vulnerabilities, our own biases, so that we can be, we can be better observers, we can be better listeners, we can provide better services, because we will match what that family needs much better. Champion children's rights globally. Again, that's a huge topic right now, but it's always been relevant, and it will be relevant, unfortunately, for a long time. Children cannot speak for themselves, so we have to be their advocates. Working to acknowledge our privilege and combating discrimination when we notice it or when we know it's there. Recognizing and respecting non-dominant bodies of knowledge. So this is something I'll share really briefly. So in my own process, what I have been learning is that I keep thinking, oh, I'm really open-minded. I accept all people. I'm learning from everyone, from all people. And then I'm noticing like, oh, maybe I was really in my dominance, from a privileged background, growing up in the Netherlands, which is a great democratic country. I've been really lucky, had a good education. I've had my challenges too, but I had so much privilege. I was able to move to the United States because I had a research job, and it was fantastic. And yeah, from time to time, I'll suddenly realize, oh, for example, even doing science is a Western invention, that is from my culture, but not from other people's cultural backgrounds. So this knowledge is, yes, it's valuable, but maybe I'm not seeing other valuable knowledge that I thought I saw, but maybe I wasn't open enough. So I would encourage all of you, as you're listening, to reflect on these things like, okay, maybe I don't know, maybe I don't know where I am really steeped in my own culture and not aware of other people's beliefs and ways of living and ways of seeing the world. With that, we honor diverse family structures. In research, we've typically, in the type of research I've done, we would typically watch one baby and one parent, typically the mother. And that is not very, that doesn't really reflect all these other ways that babies grow up in with different structures of different adults, family members, or with single parents. Language can be very powerful. We can hurt with language and heal with it. Related to that is supporting families in their preferred language can help us get closer to them, understand them better, and feel them more respected and heard. And allocating resources to systems change. I think a lot of us are in that business right now. We also need to diversify the professional field, and definitely I have seen a lot of good developments in that area for the past, well, at least past 10 years or so. I've seen a lot more diversity in my students as well as colleagues, and it's really, really good development. And then advancing policy. And with all of this, I do want to also say that we are always where we are. So we can always expand more. And like I said, we may not know where we're not seeing what we don't know, but use what you have to do what you can to continue to open and become more aware, and to go against any discrimination that you might feel in your own self and see in others. In research, we have, this paper, again, was written by Dr. Marva Lewis, who I mentioned a little bit earlier. And she and a couple of colleagues wrote this paper in the Infant Mental Health Journal, which they called Centering Blackness and Disrupting Systemic Racism in Infant Mental Health Research and Academic Publishing. So once again, this is a field where I wasn't even aware that I was viewing this from basically a white, middle-class, highly educated perspective, until I realized I was by learning this knowledge. And we're becoming much more aware, we're diversifying this research. But yeah, we've had mostly in the past samples that were white, middle class, highly educated. Not only that, but also even the research questions were thought of by white researchers. The studies were designed. I always think of survey research, and in surveys, I don't know if you feel this way, but when you fill out a survey, do you ever have that feeling of like, I don't know how I'm feeling on a 5-point scale? I just feel like I feel, and people in in any culture might feel that, but also here in this culture, we've become really used to that thinking, like, all right, I'll just put a number for my feeling. But it is a very specific Western way to see emotions, for example. So yeah, the whole publication process has been mostly white, non-Hispanic. And this one I thought was really interesting, that I also did not realize before. We tend to see and treat whiteness, so what is so-called normal or expected or good or positive, in those white middle-class cultures, which are, by the way, dwindling, we're treating those as the norm. And then everyone else is compared to that. So for example, in studies, we could have conflation or mixing up of socioeconomic status challenges and race or ethnicity. When we compare children, for example, in a Black low income situation, to white kids who are middle class, so they have way fewer challenges, then that's setting up an unfair comparison. And the risk is that we tend to focus just on the risks and not on any positive adjustment. And this is not only a disservice to the people that we are not highlighting their strengths of, but also to science and to practice and working with families. And a student of mine was kind of helping me, making me more aware of this, when I had a discussion question where it was on Native American, the history, the traumatic history of Native American populations. And I had students discuss that. And then I asked for what are some of the positive things that the Native American parents could bring to non-Native American parents. And this student was saying that perhaps even that question could imply that that it's still coming from this white-centered perspective that I have. So I'm not saying that that's bad of myself. It's just, we can continue to evolve our perspectives and look at the situation from more and more complex angles. And a practice in infant mental health that really helps with that is reflective practice, or in any field, really. So when we intentionally reflect on our work and ourself with curiosity, self-awareness, we can continue to expand our perspectives and understand people from different perspectives. Reflective supervision or consultation is an essential part of the field of infant and early childhood mental health. What does this mean? Basically, we want to offer a space where the professional is listened to. They can reflect on their work, especially challenging cases. Oh, sorry, I went a little too fast. And by supporting this professional, we are supporting the caregiver and the infant, because by holding space and being that listening, co-regulating other for a professional, the professional can then become this support co-regulating person for the parent, and the parent can then feel what that feels like on the inside and be that for the infant. What this practice also does is holding safe space for topics that may be uncomfortable to discuss. So we, of course, set some ground rules and some parameters that create safety and trust. And within that, we can explore topics that are difficult to discuss. This way, we keep evolving and keep learning about ourselves and others. And it's important to remember, I love this picture. I don't know if you've ever seen it, but we can see some things of another person. And we still don't really know what that means when we see them. But there are so many things that we cannot see when we meet a person for the first time or even the 10th time. And so again, we want to be comfortable with that not knowing, and we want to practice expanding our understanding. So diversity, equity, and inclusion. I wanted to add these definitions because it's basically implied in this topic. So diversity is all the ways that we differ in so many different ways. Equity is fair treatment, where all people have access to the same resources, the same opportunities, and your identity doesn't matter. Everyone has access. Inclusion means everyone has a voice, everyone can make decisions, everyone has the same level of authority. And of course, there's going to be authority, leaders, and but within the realm of diverse people, everyone has the same chance of being a leader. So let's look now at some disparities in infant and early childhood mental health that are related to race, ethnicity, cultural factors. First, again, definition. Let me look at the time, because I do have a couple of interactive slides, but I think I will continue and do some interaction later. So there is this definition. This is from the CDC. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So the key word here is preventable. There's another one by the National Institutes of Medicine that says differences in treatment or access, which is not justified by the differences in health status or preferences of the groups. So you could have, there's some, for example, genetics illnesses that are more common in one race or the other, or, conditions that are more common. And so then if there are differences in treatment, that could be due because there are real differences in health needs. But disparities happen when it's not justified by that. So there's the same, risk, same needs, but not the same access. So let's take a look at Utah. As you all know, we are a predominantly white state here. We've had a growing Latino population though, as well as multiple other people of multiple races, and small percentage of Black African American people, American Indian and Alaska Native people, and Native Hawaiian and Pacific Islander. Pacific Islander, we have a larger section of the Pacific Islander population than in other places in the United States. So, but it's still a small percentage. But that doesn't mean that, the size of the percentage doesn't mean that we need to give more or less attention to any of these, because also in a way, race is it's helpful. It's tricky because there's in a way, as you probably have heard, race cannot really be biologically pinpointed by particular genetics. It's all, every person is a mix of all of different ancestral genetics. But at the same time, race is a real thing. It is basically what people identify as. And so basically I'm saying this here at this slide because we can see these, these numbers, and these are self-identified. And so, but I know some people may not always know, like, okay, what am I exactly? What group do I belong to? Which box should I check? Because these are pre-selected groups. And, you may actually not always identify with that particular category. A big picture item that I do want to mention is economic and income and wealth inequality. So in 2016, the America's richest 400 people had a collective net worth of more than $2 trillion, which is more wealth than the entire Black population and 1/3 of the Latino population combined. I'm putting that here because that makes life so much harder to have this wealth that is there in the country, to have it divided so unevenly that the 400 richest people have a graph that if this graph would be the people that wrote the paper, they said that if this graph was to scale, this bar here would be 3,000 feet long. That's how much money 400 people have, or wealth. Wealth means, your assets and everything. And then, at the bottom, there are Black, Latino populations, Native American and other categories of racial census categories are not even on here because they are smaller. But yeah, it's just very uneven. And you can see this in this picture here. The balance really does not go to a fair scale. And so that makes life difficult. Here's some numbers that I'll go really quickly through. So pre-tax income has apparently increased since 2021 to 2022, but Black American and Hispanic households had less than, about like 3/4 or less than white non-Hispanic households. And post-tax, because we've had a lot of pandemic tax relief that is no longer there, and so the actual income has decreased. And babies are born into these social, economic, and historical circumstances. I also want to briefly stop at trauma and intergenerational trauma patterns. Thomas Hubel, who is he's many things. He's a mindfulness teacher, mystic, trauma expert. And he says there's individual trauma, ancestral trauma, and collective trauma in our society. When we are driven by trauma, we tend to respond to any new situation with old patterns, because trauma patterns are there to help us stay alive. They're there to keep us, out of danger. So we may show up in new situations with defensiveness, anger, avoidance, dissociation due to our old patterns of trauma that we're repeating. We may be aware of some of the sources of these patterns, but there's always ones that we cannot see. And trauma interrupts the process of relating. And basically, the field of infant mental health is trying to foster relating. So it's an antidote to trauma. And let me see, I want to make sure I have enough time, but this video is really short. So I'm going to briefly play this video, and then there's another one that I'll play.
Relationship is really what we're talking about. So even as you're talking about integrating parts of our body, that's actually, your arm is in relationship to your chest. Your torso is in relationship to your lower body. There's a relationship in how you move. And sometimes we bypass certain aspects because we don't want to feel it. But relationship is at the core.
See, we can
Trauma
hear it, but
interrupts relationship in our own body and also with other beings, other humans.
Okay, you can't hear it?
We can hear it. We can hear it. We just can't see it.
Oh, you cannot see it. Oh, okay. Okay, then I probably didn't share correctly, so I will share again. Thank you for letting me know. I'll just share my screen. Can you see it now?
Yes.
Okay, good. That's very short.
We are talking about how do we expand our field and feeling so that we can be aware of the web of relationship that we're already embedded in and be able to feel into that.
Okay. And now can you see my slides again? Yes. Oh, thank you. Okay, great. So I have another video that I really like. So this one is about, it's the same, this is an embodiment teacher, and the next one is about interrupting trauma cycles. That is related to babies, and I think it's really illustrative. So I'm going to show that one now.
Now, this year, I became a parent, and I think a lot about my father was really focused on being seen, being valued as a man in the society. And sometimes he'd look at me and I would feel that that was the preoccupation, that he couldn't see me fully because that was inside of him, running inside of him. And so I learned to kind of pull back. But when I had a child and she looked at me and it was just pure presence, the habit energy I have is a pull away a bit. That's what I'm used to doing. But I realized in order to interrupt actually the generational pattern, I had to figure out how to be present to her looking, to her eyes. And that actually, if I pulled away, I would let this story, let this pain continue. But if I figured out how to show up to her looking, something else was possible for our lineage, you know?
Yeah. I don't know, I find it very powerful. It is because a lot of the way that we transmit these trauma patterns is in nonverbal patterns. And she was talking about her father having that pattern of not really looking at her. And we saw earlier, you know, this looking, seeing the baby, seeing their existence, respecting them, celebrating them is so important for that child's sense of self and their sense of self-respect and their sense of self-love. And so if you have patterns where you subtly just look away when the child tries to connect with you, which could be due to, you know, family patterns, and these family patterns are rooted in in history of entire peoples. So Native American history, of course, is very painful. It's Native American Heritage Awareness Month right now. And so I think it's really good for all of us to acknowledge how painful and how much this still is in the present as well. This practice of the forced removal of Native American children to be sent to boarding schools, for their language to be eradicated, their cultural habits and patterns and rituals to be punished, and their family connections to be disrupted. And I have a story of a couple years ago, I heard this early intervention specialist who was working in San Juan County and visiting a Native American family and knocking on the door. And the grandmother was there. Grandmother didn't not open the door. And they tried multiple times to get there. But this is, this is understandable, that if you have had this experience of your children being taken away by white people, basically, and then another person shows up that's from some organization that they don't know if that is now, if we can trust that now. These patterns go really deep. In African American history, of course, there's slavery, abuse, racial discrimination for centuries. And for you, what is it for you? What's your ancestral history that shows up still today in your present? All of us have patterns that are based in these, patterns that are, sometimes maybe just within a family, but we're talking now about systematic patterns that affect entire groups of people and that are unjust. I love this quote, yo soy yo y mi circunstancia. I am I and my circumstance, because we cannot see our individual self as separate from our circumstances, and we need to keep that in mind when we work with people. So I see I only have about 10 minutes left, so I'll try to go a little faster. So the state of babies currently in Utah, in the nation right now, actually more than half of the babies are infants and toddlers of color. So really the word minority is not really accurate anymore, because we have more babies of color than white babies basically now. And in Utah, we have about 29% of babies are children of color. I'm not going to go through all of these statistics. You can look them up. There's a comparison between Utah and the rest of the nation. But as you can see, yes, Utah is still a very white-centered state. And the purple bars are Utah and the orange ones are national. And these are a bunch of more statistics that I'm just going to skip for now. So I wanted to briefly go over perinatal health disparities. So unfortunately, we know that infant mortality, it has decreased overall, but it's still the highest for non-Hispanic Black populations and Native Hawaiian or other Pacific Islander populations, and American Indian populations are also really high. And also maternal mortality, unfortunately, actually has increased, and the highest level was for American Indians and Alaska Natives, which is so baffling because, with all the medical expertise that we have, it's just incomprehensible. So here are the numbers, and they're just way too high. And these mortality rates, as well as higher preterm birth rates, are not just due to socioeconomic status like poverty or less access to healthcare, because higher educated Black women of middle to high socioeconomic status still have higher preterm births, still have more maternal mortality and more infant mortality. So it's not due to just socioeconomic factors. Black and Latino infants tend to also be cared for in NICUs, neonatal intensive care units of lower quality. In one study, 6% of Black infants were cared for in high quality ones and 76% in low quality ones. So even if we control for social and economic factors like income, racial discrimination is related. There's still disparities. So, for instance, African-American women who initiated prenatal care early on still had higher rates of infant mortality. And weight, obesity is a risk factor, but African-American women of normal weight were at higher risk than non-African-American ones who were obese. Some factors related are less access to good housing and neighborhoods. Historically, neighborhoods were actually, there were zones in many cities that were reserved for people of color, and we can still see that today, these same patterns. Children, infants, and their families of color have higher exposure to environmental pollution and stresses, less access to good food and all the educational opportunities, many things. And there's more and more attention now for how place matters, where you grow up matters. And this is really cool. I, again, don't have much time, but there was, for the entire United States, a Child Opportunity Index created that shows an overlay of every neighborhood in the United States and how much opportunity there is. So this is Salt Lake City, where some of you are located. I'm located here in Salt Lake. And we can see also the, we can overlay.
Oh, Elsa, you just muted yourself.
Elsa, you're on mute.
Unmute. Okay, now I'm unmuted. It disappeared because my screen changed to this other screen and somehow it muted me. I don't know why. But anyway, yeah, this is really interesting. So I would say all of you can play around with that and see the different population statuses. So for example, here, Rose Park, the majority of children there are Hispanic. And then just east of that, the majority of kids are white. And that's a pretty rich neighborhood over here at Capitol Hill. So I'll stop sharing that for a moment, but I just think that's a really interesting data to check out if you're interested in looking at your neighborhoods that you work with. You can look at the opportunities for kids there. Okay, now I'm kind of lost. I need to share again. There we go. Yes, we are. Oh, wait, I need to go back to the slides and current slide. Okay. Yeah, so obviously, as you probably can expect, children of color are having typically much lower opportunities just because of where they are born. Also, from early on, education is a great doorway to opportunity, but even by 18 months, toddlers growing up in poverty are already behind in language development. So yeah, that's true for any family, as well as peer acceptance or rejection in school is a factor that predicts later academic, but also social and mental health wellness or challenges. And we know, unfortunately, that teachers have a lot on their plate, and teachers are trying, they love kids, they're trying their best. But in many cases, many schools, the teachers are still predominantly white. And from multiple research studies, they found, you may have heard about this one, where they had teachers look at 4 kids, and they were asked to indicate the earliest signs of any behavioral concern by pressing enter on the computer. But instead, the researchers were actually looking at where where the teachers were putting their eyes. And so they had eye tracking equipment, and they found that that they were looking mostly, unsurprisingly, at the Black boy, expecting apparently more behavior problems, as well as there's more disciplining of Black boys, more conflict that teachers experience with Black boys, as well as perceiving Black children's facial expressions more frequently as angry. And that has actually happened more with girls. There's also the famous finding of Black boys being more likely to be expelled from preschool, even though they are a smaller percentage of preschool students. Okay, I'm going to skip a couple of slides so that I can share a couple of interesting stats. Oh, my battery is running low. Sorry, I have to plug in.
And
Sorry
so,
about that.
Ilse, I'm going to also ask you to kind of wrap up so we can get to our case presenter and do our breakout group.
I know, I'm sorry. I always have too many, way too much information, but
it's all amazing. Thank you so much for sharing it.
You are welcome. I will share the most interesting study on disparities in mental health that I could find that was surprising to me. So these slides are all, by the way, about perinatal mental health, and we know that there are issues with access. And this qualitative study found that women, African-American women, often found it difficult to find a provider that they could trust because of multiple factors, but one of the factors is definitely mental health. The whole mental health system was also created by white people, and they don't always feel heard and understood, or as if there's space for them in there. But I do want to share doula support has improved birth outcomes, including can have very beneficial effects on postpartum depression and anxiety, as well as postpartum PTSD. So doulas are amazing. And yeah, there was a Hispanic organization, Ciudad Materna, I don't know. I think I'm pronouncing it wrong, but that's a great group that's providing doula services for Spanish-speaking Latina women. So there's a bunch of resources on perinatal mental health. But basically, older kids have indicated that they have less access to mental health services, even if they have mental health concerns. But this one was interesting. They found that with the same level of ADHD symptoms as seen by professionals, teachers indicated more symptoms of ADHD in Black children than parents did. So basically, the teacher saw more symptoms, but the parents didn't. So this could be a form of bias. So yeah, Black children were rated to have more inattentive and conduct problems than white, but only when rated by teachers. This one is the study that I really want to show you, because this is about early childhood mental health concerns or behavioral concerns. So this was a very large study, and they tracked the children every year when they did their well child visit, and the parents filled out a strength and difficulty questionnaire. They found 4 groups of children from age 2 to 6. Some kids were stable, so they did not have many behavioral problems. That was the majority. Some were decreasing. They were having problems at age 2, but then they went down. And then 2 groups went up. So about 70% of kids had increasing problems over time. Now, which racial ethnic group do you think had the highest risk and gender, race and gender? Just think of it in your mind. And I'm going to share with you the results now. So all the groups with higher behavior problems were more likely to be boys, as we know from many other studies and also practice. But they were also more likely to be white. This was a low income, so a group affected by poverty. But yeah, white boys were basically the most at risk for high or increasing behavior problems. And then also these social risks, caregiver with depression. And yeah, basically Black children were more likely to show decreasing problems over time. And that really goes, that goes against that stereotype that many people have that we see showing up time and time again. So yeah, so then the services are often less accessible for kids with color and parents. Autism, children are less likely to be diagnosed overall, misdiagnosed, diagnosed later, and not receive intervention on time. And this can be due to many different factors, including parents not really recognizing ASD symptoms, but also maybe the doctors not recognizing them and or not helping the family. Yeah, autism resources. This is another one of those geographical data projects. And they found that there were a lot fewer autism resources in neighborhoods where there are many kids of color. So in other words, it's harder for them to access autism resources than for white children across the country. And some areas are better than others.
And then
But yeah.
all of these are going to be in her slides that will be shared on our Canvas page. So
Yeah.
it's just a great information, Elsie. I'm going to have you stopped sharing? I'm going to turn the time over to our amazing, the case presenter that you found, that you have, Sophia. So Sophia, if you want to come on. I don't mean to cut you off. It's all, I could listen to that forever. I just want to make sure we allow time for our case presenter.
Yeah, thank you, Ilse. That was amazing. And I think that is so important to remember how essential it is to be sensible when it comes down to ISS. And I think that is so sometimes even within ourselves, I know that I have to stop and remember. I have a case, and this is a real family that I want to share with you. Okay. And my name is Sophia Rominger. I am the parent liaison here. Help Me Grow Utah. And a little bit about this family. I know that this is a lot of words, and I apologize, but I want to make sure that you all have the information. So when you go on your groups, you know what it's all about. Our mother, Sonia, and her family moved from Ecuador about 2 months ago. She has a 13-month-old Mia. Baby Mia has been presenting a lot of medical and other health problems, including constant throat infections. Back in Ecuador, she was having a lot of infections and fevers. Mia is not reaching out for, well, she's not reaching her milestones, and she has been scoring in the concern areas in the skill questionnaires. Sonia also has been dealing a lot with anxiety. She's been struggling with mental health, and she is not having any concrete support. She doesn't have any family here. She doesn't have any support systems. She doesn't know anyone here in the United States. She also has other children. She has a 14-year-old daughter and a 17-year-old son who has autism. She also has her elderly father, who she takes care of for as well. And her husband is the sole provider for the family. He is the only one that has an income. Unfortunately, he doesn't have a working permit, and he doesn't have a steady job. So he works whenever there's an opportunity, but unfortunately, jobs are scarce and inconsistent. Sometimes he only has a job for 3 days a week. Sometimes there's no jobs for that a whole week, so there is no income. Sonia also struggles, like I was mentioning, with her own mental health and lacks any social connections or support. She also has no help or knowledge on how to navigate social services here in the United States. Sonia also, she doesn't speak English and she doesn't know anyone that can translate for her. So that also has been a struggle to call for services, and she feels very overwhelmed with Mia's constant health concerns. Another thing is that she doesn't have any money for her medical care, and she is currently without any health insurance. Another thing with Sonia is that she is very fearful of going to institutions because she thinks that they could report that her husband is working under the table. So a little bit more about the primary area of concern is that Sonia has been in the country, like I was mentioning, for 2 months with her 3 children. Her whole day goes around taking care for her children and her elderly father. She's trying to adapt to a new country. This comes with a whole new culture for her. Another thing too is that she doesn't have a car. And as you know, living in Utah without a car is very challenging. And so moving around for her without friends, without her husband at home, is very difficult. And on top of that, her mental health is deteriorating. Now with her 13-month-old who is presenting all these developmental issues and her health concerns, her husband being the only income and lacking of her the working permit issue, not consistent income, no medical insurance either. So taking the baby to a medical provider is very, very difficult. And also just thinking about, from a standpoint of paying in dollars is very scary for her. Because on top of everything, she thinks I have to pay rent, I have to buy food, and uh, her basic needs for her other children also have to be covered. She also has her other son that has autism, and her father who is also, you know, he also has needs, and so she's very overwhelmed. So basically, this is Sonia. She is a real person, and she is very, very overwhelmed. When we think about the 5 protective factors, basically she has none. So that is our case. I know that I went over really fast, but basically, what I want you guys to think about is what are 2 or 3 things that you can provide suggestions for. What help could we offer to Sonia to strengthen her social and emotional competence? What are things that we can encourage her to cope with her mental health and deal with her anxiety? And what are services that we can offer to benefit her and her whole family as well?
Great. Thank you so much for sharing that. We're going to put us in breakout groups. So Heather, your group is going to take question number 1. So what help could we offer to strengthen her social and emotional competence? JC and Rebecca, you are going to take could we encourage her to cope with her mental health and deal with her anxiety? Stephanie and Susan, your group is going to take what services would benefit her and her family. And then Kurt and Jennifer, your group is also going to take question number 1. So we are going to break into breakout groups, and we'll have about 15 minutes and then we'll come back. Thank you. Make sure you take time to introduce yourselves, turn on your camera. Let's provide a lot of really great recommendations for Sophia.
Now, who did you say is facilitating with me?
Jen Morgan.
Jen Morgan. Okay, thanks.
Does everybody see their breakout groups to join? Shirley and Cynthia. Do you see those? Cynthia, do you see your breakout group to join? Again, if you'll just take a minute to fill out those surveys. Hub members, if you will be sure to send your recommendations to Bailey. Bailey will drop her email in there. She'll be compiling a list, and then Sophia, we will send out the list to you after we get those all compiled of all the recommendations. Again,
Thank
I
you.
appreciate everybody joining today. What a great session and lots of useful information that was shared. Our next session we will be doing in January, so January 17th of 2024, and it will be covering social emotional health and development. So hopefully you guys will join us in the new year. Thank you all and enjoy the rest of your day.